today I will be covering the empirical therapy of pulmonary infections, especially pneumonia and urinary tract infections. So, what do you guys understand by empirical therapy? So, empirical therapy means these are the treatments which we give on the basis of the knowledge and practice. And it does not have any evidence like to prove the infection caused by Streptococcus pneumonia and you should do a culture, no? So patient comes to you and with the symptoms and all you should diagnose the patient suffering from pulmonary infection pneumonia. So before you send the culture, you should give some antibiotic to relieve the patient. So to do that, you should have knowledge and practice the specific antibiotic and their bacterial properties. So today I am covering few uh, infections and their causative organisms. So pulmonary infection, especially pneumonia, is of two types: community acquired pneumonia and hospital acquired pneumonia. So when we see community acquired pneumonia, these are the bugs which generally cause community acquired pneumonia. It consists of Streptococcus pneumoniae, Haemophilus influenza, Roxella, and atypical types. So to cover this specific, before you get any culture, you should know what are the antibiotics which can cover these bugs. So first line therapy for community acquired pneumonia is fluoroquinolones. And on fluoroquinolones also you have two types: fluoroquinolones which cover respiratory infections, fluoroquinolones which cover urinary infections. So under fluoroquinolones which cover respiratory infection, we have levofloxacin and mofloxacin. So after that, beta-lactam antibiotic. In beta-lactam, ceftriaxone. So and after that, doxycycline and fluoroquinolones, beta-lactam and doxycycline are the first line therapy. Then after that comes the macrolide antibiotics, which is azithromycin and erythromycin. So similarly, when we see hospital acquired pneumonia, these are the two bacteria which generally cause hospital acquired pneumonia: MRSA and Pseudomonas species. MRSA stands for lymphocytic resistant Staphylococcus aureus. So to cover this, first line choice is vancomycin. Vancomycin covers methicillin resistant Staphylococcus aureus, and to cover Pseudomonas species, we have piperacillin, ceftazidime, and cefepime, and aminoglycoside is a second line therapy. It is generally used in combination with these drugs. So similarly, coming to the urinary tract infections, we have first pyelonephritis. So these are the causative organisms which cause pyelonephritis: Proteus, E. coli, Klebsiella, and Enterobacter. I think these bacteria we have seen in this hospital also. I have not seen these Proteus. So to cover pyelonephritis, first line therapy will be ceftriaxone. So along with that, fluoroquinolones, which include ciprofloxacin and norfloxacin, and aminopenicillins, which include ampicillin only. So again, when we see acute cystitis, same bacteria, same. And for acute cystitis, the first line therapy is nitrofurantoin. So after that comes the Bactrim, trimethoprim, and hydroxychloroquine, but this is contradicted in pregnant women. So after the nitrofurantoin, we mostly go to fosfomycin and ciprofloxacin due to the second line again. Similarly, when we see complicated UTIs generally are caused in hospital only because of the hospital infection due to catheter. So for this UTI also, MRSA and Pseudomonas are the common bugs. Along with that, we can see Enterococcus bacteria. So to cover Pseudomonas species, we have peptides, cefepime, and some aminoglycosides. So Glyphosate usually is not seen because of their adverse effect. So, and to cover the MRSA and enterococcus, we have vancomycin, and to cover enterococcus species, we have aminopeninicillin, which include ampicillin and sulbactam, and amoxicillin clavulanate. So, this ampicillin and sulbactam is generally used in pediatric patients, and amoxicillin and clavulanate is used in adult patients. So this is like the brief history of bacterial coverage of some antibiotics. So if we see the guideline, like exactly how you should start the antibiotic empirically or after you get the bacterial culture also, before knowing the bacterial susceptibility. So generally, if the community acquired pneumonia, if the patient is admitted to patient is in ward, then first antibiotic is ceftriaxone plus doxycycline. And if the patient is allergic to beta-lactam antibiotics, then we go to fluoroquinolones. Then again, if the patient is in ICU patient is admitted because of the community-acquired pneumonia, then we have ceftriaxone plus azithromycin. These two drugs are used in combination. And if at all patient in ICU patient develop MRSA or beta-lactam allergy, if patient is allergic to beta-lactams, then we go to vancomycin or fluoroquinolones. And similarly, if patient comes to OPD for outpatient for pneumonia, first amoxicillin is preferred. Amoxicillin is 1 gram amoxicillin thrice a day is used. But if the patient is suffering from any other commodities like the heart disease, lung disease, or kidney disease, then the amoxicillin dose is